I'd like to extend a warm welcome to members of this committee, to the Provincial Minister of Health, Dr. Namafrench Mbombo, as well as the Head of the Provincial Department of Health, Dr. Keith Clutty, as well as officials from the Provincial Health Department, members of the public and media joining us this afternoon. I would like to also welcome Honourable Botha as a permanent member to this committee. I have received apologies from Honourable Christians and from Honourable Dugmore, and I believe that Honourable Botha will not join us this afternoon, and that Honourable Mackenzie will be in her place. All right, before we get going, I'm just going to quickly run through the rules of engagement for virtual meetings. All members are muted at the start of the meeting to avoid background noises. If you would like to flag a point of order, if you could please do so using the chat function or by using your raise hand button. We ask that audio and video be switched off so that we can improve the quality of the connection. There are quite a number of us on the line. However, if you would like to make any input, a member, minister, the HOD or any official, please do use your camera and your microphones. We ask that you then turn those off once you have concluded your input. We ask that presenters unshare their presentations once the briefing has been concluded. And then finally, the directives for sittings of the House and meetings of committees by electronic means are the directives which we're using today and which were ATC'd on Friday, the 17th of April 2020. So just by way of introduction, globally, as of yesterday, 1.7 billion COVID-19 shots have been administered around the world at a rate of 29 million per day. At a total of 650,000 vaccines, South Africa trails at least 12 African countries in terms of the percentage of population that have managed to receive at least one vaccine. Our South African mass vaccine rollout started last week, and as the people's representatives here in this provincial parliament, we have asked the Health Committee to come and brief us so that we can know how it's going, when citizens can expect to receive their vaccines as a third wave hits our shores, most notably in other provinces. And how can we speed up the rate at which we can get jabs into arms to try and reduce the effect of the third wave in the Western Cape? We hope that as soon as possible we can reach what they call population immunity so that we can start to enjoy an opening up of our society. For the moment, the talk seems to be about greater restrictions because of the surge in infections that we're seeing all around. So on that note, we're very grateful to have the Health Department here that will be talking to us about the COVID-19 indicators, what is the situational analysis in our province, as well as then the important progress report on the vaccine rollout, and then also questions about the various strains being seen around the world and whether these are now prevalent in the Western Cape or not. So I'm going to then hand over to Dr. Clutty and his team and the Minister for any introductory remarks, and then we can move straight on to the presentation. As usual, we will allow approximately 45 minutes for the presentation, and thereafter we will move on to questions and answers. So, Dr. Clutty, good afternoon. May I hand over to you?
Good afternoon, Chairperson. Minister Mbombo is in the audience, so I'll hand over to her first, and then I'll proceed after that. Thank you.
Thank you. My apologies. I didn't see the Minister on my panel. Good afternoon, Minister. Thank you very much for joining us. Please be welcome.
Okay. Thank you, Chair, and good afternoon to the members. Sorry, I'm on the road, so I'll just do the introduction, and then I changed to the phone so that I can do the audio. Yes, indeed. Thank you. On the three issues that Dr. Clutty is doing the presentation, but in summary, as part of the introduction, on the indicators, as we already presented during the DigiCon, that we are indeed on resurgence. which is, according to the epidemiologists, we could have a third wave around about the first week of June, around about the 4th or so, depending on the behavior or any other changes in regard to the vaccination and also in regard to the other outside factors. For example, at what extent that the impact of even the old persons being affected or infected. There is a definition of such in regard to what is the resurgence. Dr. Kluter is going to do the presentation around that. On the issue in terms of the vaccine rollout, the members might recall that we still have to finalize the phase 2, the phase 1B of the healthcare workers, which is, it meant that at least the first week when we started, we have to prioritize those who were not part of being vaccinated in the 500,000. Hence the slow in terms of the uptake, and in order to balance the 90% of the doses that have to go to the healthcare workers, and then the 10% sort of that have to go to the older persons. And it's on purpose that we started like that gradually, where now we increase the sites. We envisage about 70 sites in the metro and about 200 plus in the rural areas. Whilst it is mandatory for the people to register before they get vaccinated, however, each and every area, each and every context will be influenced in terms of what is the behavior, and also what is it that they could be done to customize the rollout in a specific area. Like now, I'm coming from Khayelitsha in Makaza, where you'll find that already, I think it Mrs. Plain as well, where for them is about they've already started to register and vaccinate in some of 2 community halls, whilst in the health facilities, it's about the people who already will have had the SMSs and then have an appointment. So each and every area will be influenced by each and every area. Also taking note, at this stage, we are still on the Pfizer, and Dr. Kluter will indicate in terms of when there's an expectation on the J&J, which is initially it was going to be 260,000 doses to be added. But also there will always be some changes here and again based on the lessons learned. Of course, the issue of the registration, it talks about also the access, equitable access to data. Hence, the City of Cape Town assisted us with access to the Wi-Fi centers in their libraries, and within the local government space in the 2 songs and e-centers, so that we could be able to vaccinate. And we've beefed up, added more of the healthcare workers who will be able to conduct door-to-door in some of these areas, and also to piggyback on, for example, with the SASSA, during the SASSA period of payouts, where you can target some of these older persons even when they're queuing for their grants. Taking note, lastly, on this issue, Chair, the Western Cape has got more of the people who are in the institutionalized or congregated settings. I'm talking about the old age communities, people, which is the old age and the retirement village, which is as part of that 720,000 plus of the older persons. We've got the people who are in the congregated settings, which is their process is different, because we don't want a situation where we're flooding these protected old persons who have been institutionalized, and then bring a lot of people who end up being infected. Lastly, about the variants. In South Africa, actually everywhere, we need to note that a virus by its nature, whether it's COVID or any virus, it will always mutate. There will always be variants. So it's not about a surprise when we say there's a vaccine that was detected in South Africa, India, Brazil, UK, and everywhere. It will always be like it is not necessarily unexpected. But each and every epidemiology will be affected by other various factors within the context of those, like with the one that was detected in South Africa, the B135 or the YV2, it showed that it is highly transmissible. And for example, the one that is detected in Brazil, where it found that it was resistant to some of the vaccines that were detected, and the one that was detected in India, where we'll find that it has got various mutation ways which becomes different. So my point is about we mustn't only think only about one variant coming from or being detected in one particular country. Each and every variant will respond differently, plus also not all respond differently. It could be there are many of the, we call them VOCs, variants of concerns, which could come any other time that we might have an impact also in the context of the Western Cape. Just a caution that you mustn't zoom too much on one specific variant, but it is crucial for us to share that kind of information. What is the preparedness in regard to that? But noting also that people travel everywhere. Like that variant originally detected in India, it's more than 20 times plus, I think, already detected in the UK, meaning that we don't even have direct flights from the India. People can via the UK. At what extent? Now that you only zoom in only to those who might have been from India, yet there are many, all of those in the other sites. Over to Dr. Casey and the team. I'll switch devices and then go to the phone. Thank you very much.
Thank you, Minister.
Thank you, Chairperson. Can you see the slides?
We can, thank you.
Thank you, Chairperson. Just to start with the committee, then to understand for the last 4 times we've done this, since we send you the slides and until we appear in the committee, lots of things change. So we have daily changes, and since last Friday to today, a lot of changes, and therefore we send you an updated with the latest information. I will stick to the 45 minutes, and it will be on 4 points. It's really the surveillance and the response update, the preparation for the third wave, and then the vaccine implementation update. Just on surveillance and where we find ourselves, this is the graph that shows that in January we peaked in the second wave. We came down in between waves, and in the last 10 to 12 days, there is an increase in cases. Now, the cases are the gray bars, and if you look right to the right-hand side of the graph, there's starting to be an increase in cases. The green bar, the green line is the oxygen use. You can also see there's an upswing in oxygen use. The blue line is hospitalization. It's now a very minor upswing in hospitalization. And then the red line is it's the reported deaths. There's also now a slight increase in reported deaths. The yellow line is a very important marker. That's the test positivity rate. And that ratio has also started going up in the last 10 to 12 days. This is our mortality tracking, our deaths. And you can see that we now track our deaths very closely to the Home Affairs deaths. We've really used the time to actually be reconciled to try and find all the deaths. And it is also against the MRC's excess death report that we're tracking very well in this province. If I then go to the reproductive, if I can go to the reproduction number, and the reproduction number is how many cases are resulting in new cases. It is defined as this. So if we have 10 cases, active cases, and you have the 10 cases causes 11 new cases, then your reproduction number is above 1, and it's about 1.1. If your 10 cases only causes 9 cases, then the reproductive number is below 1, and it means you have a decrease in cases. So it's very important to understand whether your active cases are causing more cases or the same or less cases, and that gives you a sign of whether you're coming down or whether you're increasing. This is our provincial overview as of last Thursday, and that was, we saw a 25% increase last week compared to the previous week in cases generally across the province. There was about 200 new diagnoses every day, but the admissions and deaths also then started increasing, about 30 to 35 admissions a day and 4 deaths a day. And the average proportion positive then became above 5% for the first time. You can see it's been below 5 for a very long time. If you go to the metro, by last week, there was a 33% increase week on week in the metro. And there were areas that were affected mostly were northern, eastern, southern, western, and Tygerberg, and mainly private sector positive tests. So mainly people from affluent areas in those areas where the cases increase was about. If you go to rural areas, it was a 14% week on week, 50% in West Coast, and whereas the other districts had a much lower increase. And West Coast, because of its proximity to Northern Cape, then was a concern to us, specifically of its impact of the N7 and people traveling from the Northern Cape to into the Western Cape. So we've introduced something called monitoring the resurgence, a resurgence monitor. And then for 12 consecutive days, there was the number of cases increase more than 20%. So we officially are in what we call a resurgence of cases. We're watching that closely, but we've not met the criteria for being in a third wave. And the criteria for entering a third wave is whether you are seeing a third of the number of new cases per day that you saw at the peak of a previous wave. The modeling, South African Modeling Consortium is predicting that we potentially in the next 2 to 3 weeks could enter a third wave, but I'll come back to it. We can influence that through behavior. This is our surveillance notes, and you can see mainly across all the areas, it's really just about social gatherings and social events that's spreading the clusters. So you will see there was about party on a farm, there was a Mother's Day event, there's a pub social event, etc., etc. There was a school outbreak. It's really where people gather, where these increase in cases has come from. The wastewater, which is a system that's been put up by the MRC together with the City of Cape Town and 2 other municipalities, Breda Valley and Theewaterskloof. We are tracking that on a weekly basis to see whether there's increases. There was no increases detected in the 8 treatment plants, in 8 of the treatment plants in the metro. There were some increases in some of them. In Theewaterskloof, for the first time in 2 months, we saw some increase in Grabouw, and we couldn't do Breda Valley last week because of some technical difficulty. So that brings me then to our preparation for the third wave. And as I said, the COVID Modeling Consortium predicts that a third wave that will be smaller than the second wave, but there's a lot of uncertainty. For instance, the influence of variants that could emerge could impact that. But the big message of this slide is the graphs to the right. And you will see there, we talk about hospital admissions, talk about cases, and also about deaths. Now, what they are saying in the light bar, the light blue bar is what you're likely to see if we are weak in our behavior response. The dark blue bars is if you are strong and quick in your behavior response to the increase in cases. So we are advocating for a strong and quick behavior response so that we can decrease the number of cases, flatten the curve, and make sure that we reduce the admissions and deaths. Increased hospitalizations are also associated with increased mortality. That's why we need to reduce the third wave. And then we also need to limit the need to de-escalate other services. We've done it twice already. The impact is massive and the knock-on effect is massive. But probably one of the most important reasons why we should delay the third wave and flatten the third wave is that we do not interrupt a vaccine program that is about to scale up in a massive way. So it's very imperative to all of us that the vaccine program does not get interrupted. Then the question about variants. So I'm just giving a feedback on the variants first detected in India and UK. Our virology labs in our province is part of the network of labs in the country. There's not been any identification of B1617. That's the variant that was first detected in India, in the Western Cape. There's been cases in South Africa, but not the Western Cape. There's also been no further identification of B117 beyond the 8 cases that were reported early in May. Our labs have had some challenges with their sequencing machines, so there's some specimens that they're still waiting for sequence, but that's the situation as we speak. And given that the spread of B167 is in more than a dozen countries, and it's actually increasing every day, a travel ban on India has not been considered because actually there's no direct flights from India. And actually, the B167 is now in so many different countries, and it grows all the time. But what we need is vigilance at our airports. And as a health department, we've now started assisting Port Health to back up all the international arrivals at our airport to make sure that we do all our checks in terms of safeguarding the people. So the summary of the scientists is they foresee that for the coming months and the third wave, the predominant variant will be our 501v2, or as it's called, B1531, will be the predominant one. And these other ones that's been picked up is not going to make a sizable difference in impacting on our situation. We obviously have to monitor it to see that that is the case. So therefore, our third wave resurgence and response, we continue to see this concerning increase of number of cases, and we remain in the resurgence. We believe behavior change is the key to mitigate the third wave. We can delay the onset and flatten the curve until more people are vaccinated. So we call on the Western Cape community to flatten the curve with these 5 key things: ensuring consistent social distancing, mask wearing, and hand hygiene. This should be so ingrained in our nature that this is now a second nature habit for all of us. We should be avoiding all non-essential gatherings. We're also making a recommendation that essential gatherings to be outdoors if possible, and that we are calling for a reduction in the size of essential gatherings. It's a 5-point plan. So I just want to talk about a containment paradigm. So when you're in between waves, you try and contain and make sure that you don't have big outbreaks of cases. So in the containment, we have a very strong focus on picking up quick cases, clusters, limiting spread from there. And therefore, our containment paradigm is the following. That's where the 5 strategies come in. Number 1, which remains number 1, is community behavior as the cornerstone for containing the spread of virus in this containment phase. This needs to be re-emphasized so that we can delay any resurgence for as long as possible. But number 2, which is our localized outbreaks are monitored, and you can see a rapid response. That's the surveillance huddle I gave you. That's the data we look at. And we're watching very closely like hawk eyes to see for outbreaks in any geographic area. Number 3 is that when we are in between waves, our COVID capacity gets scaled down so that we can do the rest of the other services. But we have trigger points. So if the cases start increasing, we start triggering for that. And then last week, we learned the most about looking after our staff. So we had a whole process of healing and grieving for our staff. And then we started vaccinating all the healthcare workers in preparation for the third wave. When you go into the mitigation program paradigm, so when the cases start increasing, community behavior still is probably more important than anything else. And it's even more, because what we then do is for the individual risks, as the people that's more vulnerable with comorbidities and elderly, that we need to behave even more strictly. This inevitably will probably translate into how the wave progresses, but as a collective, we can flatten the height of the wave. Then our outbreak in the surveillance also then shifts from little outbreaks, but really about protecting the high-risk people. And that's where in previous terms we shared with this committee why we shift to our testing to protect more vulnerable people rather than testing everybody and trying to contain infections that is really now so established it's everywhere. And then what we do is the COVID capacity needs to scale up, and then all the other service capacity needs to scale down. And now we need to recognize that when we go into this third wave, we are asking healthcare staff to manage COVID cases and to scale up a vaccine program and to do all the healthcare work in addition. That is going to be a huge burden on healthcare staff. So it's all of our interest to really behave in a way that we maintain and flatten the third wave. Our acute platform currently, we're at about Thursday last week, 760 COVID patients in hospitals. About 5% of all COVID in all patients in public sector is COVID related. And Hospital of Hope had 17 patients then. This was our dashboard last week. We are updating it for tomorrow. But yeah, about 5% of all the cases in public sectors on last Wednesday were related to COVID. But our hospitals are still full, and that means they're full of other things other than COVID. And this is where we need to share with you that the trauma presentations over the last 6 weeks, and you can see the peaks are the weekends, And if you look to the middle of the slide, you see 25th of April, a weekend, and 2nd of May, a weekend. It was a long weekend. You can see the spike in trauma cases in our emergency units. And when you go into the middle of the weekends in the middle of the month, there's fewer cases in each of the areas. And then in the weekdays, the cases drop to a lower level. But over the last 6 weeks, we've seen a total of 11,500 trauma cases at 13 emergency centers that we're tracking now. And more than 40% of them occur on a Saturday and a Sunday. About half of these trauma cases are due to interpersonal violence. So they are imminently preventable things, but you can see how interpersonal violence puts a huge strain on healthcare services, not only healthcare services, also social care services and traffic services. But interpersonal violence is something that really needs a medium to long-term strategy to contain. Our oxygen was the other big thing that we worked on in the second wave. Our combined oxygen use is up to about 31.8 tons, public and private. Public sector is 14.6 tons per day. But we work together with the private sector to address our capacity challenges, and we continue to monitor. And we are actually meeting with AFROX this week to get our systems ready for the start of a third wave. And then our people management response, we have a COVID-19 staffing strategy. Most critical posts has been retained, making sure that people can be appointed so that when we need pools interchangeably. And therefore, we want to keep COVID as low as possible, because then we can maximally deploy people for the vaccination drive. That brings me to the vaccination update. And just to say that with Sisonke or phase 1A, we actually in the end were able to vaccinate 70% of the estimated target of healthcare workers via Sisonke. The balance of healthcare workers, which is phase 1B, commenced on the 17th of May. And that 33,900 doses for Pfizer was how we started phase 1B together with phase 2. This is the Sisonke overall picture. For the Johnson & Johnson vaccine that was used in Sisonke, we received 95,880 doses. We used 93,153. That is a wastage of less than 2%, or just about 2%, which is very, very high in terms of wastage, very, very low in terms of wastage, in terms of the maximum use of the vaccines at our disposal. It ran from the 17th of February till the 15th of May, and now the remaining healthcare workers is part of phase 1B. To go into phase 1B, just to illustrate to the committee, the strategy is to have small to large public sector sites. The public sector sites is like the backbone of the vaccination program. But on top of that, we're going to add maybe donor-funded mass vaccination sites. And I'll come back to that. And on top of that, you add the private sector sites. And on top of that, we're going to have a workplace program, both for private and public sector. But all of this under the governance of the geographic area, and it's the district geographic teams that pull all of this together in each local geographic area. This is the adjusted timelines from the national program. On the 17th of May, we did the over 60s together with the healthcare workers. And then we transitioned from one band to the next when we reach about 70% of the target population. So we need to A, register as many over 60s as we can, and B, then vaccinate as many over 60s as we can, so that we prepare for the switch over to the over 50s, the over 40s, etc. This is the bands we're working with. Over 60s in this province, there's about 720,000 people. Our target is to try and vaccinate all of them before the 30th of June. And then towards the middle of June, start opening the registration for possibly first the 50 to 60, then 40 to 60, etc. And that's how we will work to start registering people, so we can have seamlessly move from one to the other. These are the provisional sites for public sector. Ultimately, we will have 70 sites in the metro, and we'll have 204 sites in the rural. On top of that will be the mass sites, the private sector sites, and the workplace sites. And we will weekly update how we progressively move to this picture. So then the launch happened on the 17th. A range of religious leaders from different faiths and Archbishop Tutu and Mrs. Leah Tutu were amongst the first citizens over the age of 60 to be vaccinated in this province. Last Monday, we had 6 sites that started at the beginning of the week for over 60s, old age homes, and for healthcare workers. A 7th site was only doing healthcare workers. That was the City of Cape Town site. These were all in the metro to start the program. Towards the end of the week, in addition to that 7 sites, we added 11 additional sites. So we ended up the week with 18 public sector sites in the metro. Having started with 7 on day 1, we were on 18 on the Friday. This is what we did in last week. All the small groups at the sites, SMSs were sent to them. They receive the SMS, they present to the site, they follow the vaccination process. The vaccine is recorded. The appointment for the second one is recorded on a card. And then we also went to old age homes. We collated all the lists. We uploaded the old age homes as block booking. Our teams went to the old age homes, the outreach teams. They did vaccination of the individual residents after checking consent with individual ones of them. And then the vaccinations were recorded, and then appointments booked for the team to go back to do the second dose for the teams in the old age homes. These were the old age homes that were targeted between the 17th and the 21st of May. A big range of old age homes. There were 6 in Khayelitsha Eastern. There was 5 in Khayelitsha Eastern, 6 targeted in Clifton and Mrs. Plain, 1 in Southern Western, but they've added 3 since Monday, and then 3 in Tygerberg Northern. So as of Monday, I'll come to that. These were last week, and this was the additional ones done. The private sector had a delayed start, so that created some bottlenecks because some people then presented all to the public sector sites in the beginning. But as of last Wednesday, Clicks brought 7 sites online between Wednesday and Friday. And we're bringing this additional 8 sites online between yesterday and today. 4 Mediclinic sites, 2 Dis-Chem pharmacy sites, and 2 Discovery sites. And then from next week onwards, from this week, actually in this week, as of yesterday, for the rest of the week, we're bringing 33 sites online. So we're starting with the 18 public sector sites. We add 33 to take us to 51. So that is where in the metro is the bulk. 24 of them have been started since yesterday for the rest of the week to get all of the sites on running. And then in rural, we started with 6 sites yesterday. And then next week, we're adding another 49 sites. So you'll see in the metro, and then the majority next week is in rural, in all the districts across rural areas from next Monday. And the week after, another 17 sites. So we're planning 2-3 weeks in advance, and that is the idea, to bring all these sites online. So what was our uptake in the first week? We did 10,289 vaccines in the first week, and that was mostly people over the age of 60. What is the lessons learned? We learned lots of lessons about infrastructure to be in place, the weather conditions, waiting time, queues. We learned a lot about walk-ins because a large number of people just walked in, and we needed to actually mitigate that to encourage people to make appointments and scheduled so that we don't have an overrun of too many people at the site, and as vulnerable people, you don't want to have super spreader events. And then we also had to learn about on-site registration. Some sites had to make accommodation for that. And then a vetting process. It's probably the saddest thing we've learned in the last week, is that people have abused the system that's under the age of 60 and is as almost fraudulently enrolled as healthcare workers so that they can jump the queue. That system has now been closed since midnight yesterday, and we now have a stringent system in place to make sure that when people present as healthcare workers, they must prove to us that they're healthcare workers. So the EVDS, which is the electronic system, the registration is the important part. So as I just said to you, the health worker registrations are closed now. The only registration open is over 60. And when you go in there and you put an ID number in there that indicates that your age is below 60, you get rejected out of the system. So nobody can get into that system because the ID number blocks you. Only people with an ID number that proves that they're over 60 can be allowed in the system. The second one is that all the facilities and vaccinators are registered on the system. So each facility and all the vaccinators must be registered to be able to be allowed to give vaccinations. They must be accredited, they must have training, they must have all the systems in place to be able to be registered. Then the scheduling is the big issue, that appointments are then made on the system and SMS notifications are sent out. Then the vaccinations are confirmed as people receive it. It goes onto the system to tick that if you have had the vaccination by name and person. So we have a record of who has been vaccinated. And then the data, and you generate the data for the dashboards to monitor your progress. There's been two game changes that has come in over the last week. The first one is that the extension of the shelf life of Pfizer at 2 to 8 degrees, which is normal temperature that you can put in the fridge. It has now been changed from 5 days to 31 days. Now that is a huge game changer. So now you can hold onto Pfizer in the normal fridge for up to a month. So that drastically now reduces the risk wastage, and it also expands our ability to go in all the geographic areas that we can use it everywhere. And our planning process can now be much more efficient in terms of being able to use Pfizer in that way. Then also the extension of the time period between the first and second dose. There's a recommendation that you can now do Pfizer at up to the second dose after 6 weeks. That also helps us because then we can vaccinate more people, and that the return vaccination is later. So we can get to more people under 60 with the Pfizer vaccines we have. So these are the targets. So having reached 10,000 in the first week, which is about 2,000 a day, this week our target is to scale up to 6,000, an average of 6,000 vaccines a day. That means we need to attain 30,000 vaccinations this week. Next week, 60,000. Then we go up to 12,000 vaccinations a day. The week after, 120,000, which means we must do 24,000 vaccines a day in this province. And that we need to maintain and possibly increase a little bit weekly until December to complete the vaccination program. So our systems are now all geared for this incremental change over 3 to 4 weeks with all those sites coming online to be able to achieve this. Just on EVDS registrations then, as of the 22nd, that was Saturday, there was 278,000 people registered over 60 in this province. That's about 38.6%. In the metro, it's just about 38%. Cape Winelands, 34%. Garden Route, just over 40%. Central Karoo, 17.4%. West Coast, about 39%. But Overberg has been doing extremely well. Overberg is already sitting close to 63% of people over the age of 60 that's registered. And then what we are now telling you about, we got a very sophisticated dashboard now. And the dashboard can find out where do people over 60 live in this province, in which communities, what is the distribution of the elderly across communities, especially with high levels of socioeconomic vulnerability. So we can match the old people to vulnerable, socioeconomic vulnerable areas. Then what is the estimated population within 1 to 5 kilometers radius of a vaccination site? And where should additional support be provided to improve registration numbers across communities? And what is the footprints, like the social facilities, libraries, Wi-Fi sites that can support the vaccination effort? So this is just 2 examples I'm going to use out of this. So firstly, out of that data, we can now break it down for you and show you what the percentage is per geographic area. So we've taken the 8 sub-districts of the metro. We've given you how many people have registered as of the 22nd and how many people are in that age group. And you can see that in Khayelitsha and in Mitchells Plain, it's 17.5%, Mitchells Plain 18.2%. In Central Karoo, 17.4%. That's the 8 metro sub-districts and the 5 rural districts. You can see in a place like Southern sub-district, more than 52% has already been registered as last Saturday. And you can see in Overberg, the one that I spoke to you about, 62.8% registration. And all the other areas are in between. So what I've done is just to give you an illustration that this dashboard can take you into any neighborhood, right down into neighborhood to say, what does it look like? So I'm using only 2. So I'm going to use Mitchells Plain that I showed you. And you can then see from Mitchells Plain on that same data what the dashboard tells you. Now, this is Mitchells Plain, the map. That's all the areas. So you can see in a place like Colorado in Mitchells Plain, 100% of people there are already registered. You can see in places like Westridge, it's close to 50%, Mandalay, it's 37%, Portland, Beacon Valley, Lentegeur, Rocklands, it all goes above 20%. It still needs to be increased. But then when you start looking at Eastridge, it drops below 20%, 18%. Beltevreden, Boys Town, Westgate, then it goes down to Crossroads. You can see 13%, Tafelsig 10%, Heinz Park only 7%, Browns Farm less than 5%, Philippi East less than 5%. Then you can see all the way down to Kosovo informal settlement, 2 people registered out of 876. Philippi Park, 0 people registered out of 329. Now this level of detail now tells us where we need to focus on all those red areas to get people mobilized to be vaccinated. And the big story here is the people do not have the means to register on this electronic system. They need somebody to come to them, to assist them with a cell phone, with data, and to just show them with 8 simple steps that they can be vaccinated. And that's the drive that we need to do. I'm going to use one rule, and this is where you take that same Mitchell's Plain, and you can see the pockets of Wi-Fi spots, where you can see the communities in Philippi and Browns Farm has fewer Wi-Fi spots in their areas compared to the other areas of Mitchell's Plain. And we've also superimposed now the same vaccine sites that I spoke about that came online this week. You can also see where the vaccine sites are in relation to where the people have access. So this team, Mitchell's Plain's team, now know what it is they need to do to mobilize and to vaccinate and to get to their targets. If you go to George, I'm taking this rural district, this is George. Then you will see in George Central, 100%. You'll see Eden, George, which is also like Central Part, Campus Drift, Lurie Park, 80%, Boerdorp, 80%. Dormits Drift, sorry, Blanco, 52%, Netherlands, 52%. Then you have, George South, Lawaaikamp, that's above 20%, but it's below 50. And then the same picture, which you will get in every geographic area in the province. The moment you start talking Rosemoor, you're talking Pakkalsdorp, it gets dropped. Conville drops lower and lower and lower. And if you go to Thembaletu, you see 7% in Thembaletu in that area. There's 2,800 people over 60, only 214 has been registered in Thembaletu. So it's exactly the same picture that you will see in the metro. People in socioeconomic deprived areas have difficulty having access to the system to be able to register. And this is, again, if you look at the Wi-Fi spots, in Pakkalsdorp and Thembaletu has the largest estimated elderly population in George, but these communities have fewer Wi-Fi sites compared to the other regions of George. So more efforts is required to support communities who do not have access to the infrastructure to register. So this is the drive. We want to do demand creation. There's a need that everybody needs to assist somebody over the age of 60 to enable them to register. Community workers need to go door to door. We need to partner with all governments, business, civil society to maximize our resources. We need to assist an elder, assist elderly family members and community members, but we need targeted drives in each geographic area, which I've shown, which is those rose areas, red areas with very low uptake of registration. And it's as simple as go to the website, click on the link. It's as simple as dialing the number on your cell phone, which is free for all South African networks, the *134, *832 hash, and as simple as the capital letters register and WhatsApp to 0600123456. And the message is, take this with you, help people. And if all of us take 4 or 5 people that we know over 60 and help them, and we have targeted drives in these areas of low coverage, we can register the people that need to be vaccinated. In conclusion, we are in a resurgence. Our call is for people to adhere to protective behavior so that we can flatten the third wave. We anticipate that the third wave will be lower than the second wave. However, it's dependent on the strength of our behavior over the coming weeks. Preparation for the third wave are in full swing. We have clearly identified trigger points for the health response. We've learned from for wave 1 and 2. We require concerted whole of government, whole of society to flatten the third wave, if only to protect the vaccination program. And we've started phase 1B and phase 2. We will now significantly ramp up and scale up capacity to administer vaccines over the coming weeks in a sequential manner in each geographic area. And now we need to mobilize and assist everyone over the age of 60 to get registered on the system. And the slogan of the vaccination campaign is, it's obviously in everybody's interest, but the slogan is, let's do this. Thank you very much, Chairperson.
Thank you very much, Dr. Cloete, for that presentation and the information provided. I'm sure there are many questions from the members, so we will approach this in our usual way. We'll go by parties represented, and for this round, we'll have 3 minutes. So I'm going to take the first. I've got 3 questions, so I'll take that time then from the DA. My first question is regarding coordination with the private sector. Who's coordinating the private sector with respect to vaccine rollout, and how does it fit in with the provincial vaccine effort? And related to that, then, how does the electronic vaccine system decide who gets an appointment first and whether to send that person to a private or a public facility? How does it determine how the vaccine appointments are decided upon or administered? My second question then is whether the amount of registrations on the electronic vaccine system, does that affect how many vaccines the Western Cape will receive? So if people don't register in advance, does that mean that potentially we could get less vaccines than what we should be getting in our allocation? So to what extent is our citizens or residents' ability to register, how does that correlate with how many vaccines we get from the national program? And then finally, my question is, what can we do as public representatives in our constituencies to help with this strong and quick behavior response? What can we do to help flatten the curve? Just want to check if any of my colleagues would like to pose further questions in the DA's time.
Chairperson, can I proceed?
Thank you, Honourable Philander. You have 1.5 minutes.
Thank you, Chair. Chairperson, through you, with regards to the demand and the capacity to respond from healthcare workers in relation to the anticipated third wave, what measures has the department undertaken in terms of additional appointments to supplement a possible absence of workers during this period? Also, Chairperson, what does this mean for healthcare workers who have yet not been vaccinated? Just adding on to that, Chairperson, have any critical posts been filled in the Department of Health that were left due to COVID-19? I think that's the time. Is it time? Can I?
You've got about 30 seconds, so if you've got one last question.
Yes, Chair. And also, Chair, I would like to ask, are there any updates from the department with regards to the recruitment database to recruit additional staff to support COVID-19 care? If that is the case, Chairperson, how many posts has been made available in this regard? Thank you, Chair.
Thank you, Honourable Philander. I'm then going to move over to the ANC. Are there any questions from the ANC?
Yes, Chairperson.
Thank you, Honourable Van Vogel. Over to you.
Thank you, Chairperson. Let me first welcome the presentation from the department. Chair, mine is on, I want to know how many healthcare workers were vaccinated in phase 1, and what is the number of outstanding workers? And as far as the farm workers, are farm workers included as essential workers, and how many vaccination sites are in farming communities, and have these been communicated to farm workers? What is the number of registrations that have been received for the second phase? And are there any facilities that have experienced challenges in, and if so, what are the common challenges and how have they been addressed? Then, Chairperson, what is the strategy to deal with chronic medical cases, and other health service during the third wave? And then my last question, Chair, to the HOD, are you suggesting that the increased cases in the West Coast have something to do with the Northern Cape? And are these seasonal workers that recently entered or left the province in the past few months? And what is the strategy of dealing with the spread in the farming community and handling the risk of spreading, especially if it comes to transporting these workers? Thank you, Chair. I'm not sure if there's anyone else from the ANC side who want to ask a question. Thank you, Chair.
Thank you, Honourable Van Vogel. I see Honourable Lekker. You have just over 1 minute.
Thank you, Chairperson. Good afternoon, everybody. I want to latch on the issue of chronic medication. Is there perhaps a plan of ensuring that those who come to get their chronic meds on appointment can consequently then be given the vaccine? And also, Chair, in respect to registration for vaccination, I'm not sure what systems are utilized, because I've been helping people in my constituency and only to find out those who did not register prior went to a library or a clinic and register, and the following day they were told to come, whilst there are those who have registered online who are still in the waiting list, or rather perhaps do not know what is happening because they hear from their peers that they've already been vaccinated. So for me, I think there's an issue with online system and how it is monitored. And then maybe I would suggest that when they collect their chronic meds, then they consequently be given this vaccine. Then the second question, Chair, is around the second question, Chair, is in relation to the healthcare workers. Out of those who have not received the vaccine yet, what is the plan going forward? Thank you.
Thank you, Honourable Lekker. I now recognise the Good Party, Honourable Heron.
Thank you, Chairperson, and thank you to Dr. Cloete for the presentation and information. My first question, on the weekend, I saw, I think it was Sunday evening, Dr. Cloete being interviewed on one of the news channels, and he said that the Western Cape Health Department had ordered 30,000 vaccines for this week, which I found quite interesting, because I assume then that the Western Cape Health Department could have ordered more than 30,000. So I'm trying to understand how this distribution of vaccines works. Is each province deciding how many they can administer in a week and then ordering them from a central distribution center? 30,000 seemed quite low to me. I think the greatest concern amongst all South Africans right now, or those who are paying attention and believe in vaccines, is certainly to get vaccinated as soon as possible. So I'm wondering why we only ordered 30,000, and am I wrong to be feeling that that is a very low amount? My second question is about about increasing the pace of vaccination. I see that we're going to increase to 60,000 next week and 120,000 the week after. That still seems quite low, and I did see that the interviewer on the television news channel asked Dr. Cloete about vaccinating over weekends, but I see we're still only vaccinating or planning for 5 days a week. Is there any reason why we can't increase the order of vaccines and increase the number of days? And then my third and final question for this round is about the private sector as well. The reasons why was there a delay in the private sector in the Western Cape becoming activated? How are vaccines allocated to the private sector? And why are we, and this is anecdotal, seeing on Facebook and social media, lots of people, and it seems in Gauteng, being vaccinated at private facilities, but I don't see the same in the Western Cape. So I'm wondering what has happened to the private sector in the Western Cape, and why is Discovery, for example, in Gauteng vaccinating what appears to be quite a lot of people, and we're not seeing the same here? Thank you.
Thank you, Honourable Heron. I now recognise the Freedom Front Plus. Honourable Murray, do you have any questions?
I feel sorry for Dr. Keith. Everybody asked 20 questions or 10 questions. How's he going to handle this? So I'm going to, I don't know if I should skip for a second round, because it's unfair towards the doctor to ask him to answer so many questions in one round. Don't you think so, Chair?
He's very well used to it, Honourable Murray. Very skilled in answering many of our questions. But if you'd like to hold over your question to the next round, you're most welcome.
Okay. Now, I just thought I will put that question. My question is a bit different. I know you did a lot of work on your doctor. I just want to know, how will the budget cuts over the MTF, how's it going to affect all your plans? How is it going to negatively affect your plans to combat diabetes and also to have enough to handle the whole issue of COVID? Because they're being cut by 20.7 billion over the 3-year period. They're cutting our budgets. Then I would like to know, maybe you can tell me whether you still recommend that parliamentary oversight committees go ahead, or should they stop their oversight visits because they're endangering members by sending them with buses all over the Western Cape to go and do oversight visits when it is not perhaps urgent or advisable? Then my main question is, I've asked in the committee, because people have different comorbidities, and you yourself says that these viruses, they different effects on different people. So why don't people have a choice on their doctor's advice to either get Pfizer or to get J&J? Why do the government decide what to give them without knowing their medical history? And then I would want your views on ivermectin. Are hospitals giving it if patients ask for it? Like the High Court, Gauteng High Court ruled that if a patient wants ivermectin on instructions from the doctor, they should be given it, because every variant, like you rightly says, responds differently. Now, in the light of that different responses, shouldn't people have a choice? The rest of my questions I will leave for next time, but I will suffice. I'll stop there. Thanks.
Thank you, Honourable Murray. We will have a second round, so you'll be able to pose them then. Thank you. Right, then Dr. Kriti and Minister Mbombo, that is quite a lot of questions. So if there were things that you missed, please don't hesitate to let us know, and I'm sure the member would be more than happy to pose that question again. Should I hand over to the Minister first or to Dr. Kriti? Okay, over to you, Doc.
Thank you very much, Chairperson. I'll try and be as concise as I can be. Coordination of the private sector, there were quite a few questions related to the private sector. So coordination works in the following way. We've been coordinating with the private sector ever since the planning started. So we have a committee that meets. Dr. Karim is our convener. He is the Chief of Operations in our department. He meets weekly with our private sector colleagues from the hospital groups, the pharmacies, and from all the entities. And they put the plans together for the Western Cape. Now, the coordination has been complicated by two things. The first one is that Business for South Africa, B4SA, have been coordinating the private sector response centrally for the whole country with the national department. So there's been communication directly between the national department and B4SA, and then in the province, we're trying to have a conversation with the private sector colleagues. The reason why there's a delay in that they started is because it was the issue about the rates to be charged and the fees structure, whether that's been gazetted, and the mechanism for charging between the private and public around vaccinations. That is the main reason why there was a delay in starting up. The second issue you asked is, how does EVDS assign somebody? The system is designed that if I live in a geographic area, my access is to the nearest sites to where I live, depending of the site is open on the system to accept appointments. So whether you live in a geographic area, you are likely to be assigned to the nearest site. So therefore, private sector sites and public sector sites are likely to get patients from one the other. But because of our history of our country, if there's a private sector site in Claremont, the people in Claremont are likely to be more on medical aid. Therefore, the private sector site will see more medical aid patients as the person in Khayelitsha. In Khayelitsha, the people living closer to that site is more public sector. It does not mean that somebody with a medical aid in Khayelitsha will not be seen in the public sector site. It is just the balance is there. But the system automatically takes geographic access and assign you. That's why, because there wasn't private sector sites in the first 2 or 3 days, people were assigned from Sea Point all the way to Helderberg, and they were in Mitchell's Plain because there wasn't a private sector site in between. So that's how the system is set up to do allocation in terms of the available slots for appointments at the various sites. Then you asked about the registrations. The national formula is however many people are registered is in a sense a proxy for demand. And the national minister has proposed that the system of allocating doses across the provinces are influenced by the number of people that's registered on the system because they're the people that have presented themselves to be vaccinated. Then I think your point about public representatives, I do think it's important to flatten the curve. Public representatives probably, and linked to member Maria's question, must promote the 6 issues that we have. Work from home, not have gatherings that's not needed, encourage people to meet outdoors, keep it small, and encourage people to wear masks and social distance and wash their hands, and not travel to areas that could introduce additional infections. So therefore, it's really the voice of the public representative, and that those messages get to the constituencies, that people make sure that the behaviors are observed in each of the areas. Then your question about demand and capacity to respond, that's the other questions that came out. We have appointed more than 2,000 healthcare workers. That is what I reported the last time I was you. We were up to 1,400. We added another 800. So we now into 2,000 healthcare workers and still adding. That is because of the budget that we've been allocated, and I showed you its budget to have additional people for vaccination and additional people for COVID. So it's more than 2,000 odd, and over the last time I checked, there's still about another 400 or 500 to go that we can add in terms of our recruitment system. And then the post that's filled, obviously when we fill the post in contract or post filled, it's a combination of all of those that's already existing in our system. Then in terms of the healthcare workers, the question from the ANC, the healthcare workers that were vaccinated in our province is 95,000. Now I put that for, 93,000. That is under the category of healthcare workers. What we have is we have a breakdown of that, of the people vaccinated within our department that works in our department. We have 35,000 people working in our department. We have close to 20,000 people vaccinated in our department. So it's close to 60% of our staff has been vaccinated. There are still a balance of staff that needs to be vaccinated, and I will explain how we're going to do that because the registration for healthcare workers has been closed. And you must remember also, we vaccinate somebody, they leave, and a new staff member comes, so it's not a constant thing. There's always a change in how many people have been vaccinated, and we have now a system to make sure that we up our vaccination amongst our staff members. Then in terms of farm workers, there's 2 questions around farm workers, if I can understand. The first one is, we have asked the National Department that we, like an occupational health and safety vaccine program, that we can register farm workers as a block, or people on farms as blocks, like we did the old age homes. We take all the names and we register, and they don't have to individually do it. National Department has agreed that we can put them on the system. But now we need to figure out the outreach to farm workers. If it is over 60, then obviously we're targeting farm workers. But if it is part of the essential workforce, then it's a different thing. So we are also busy working on how as I said, the public and private sector vaccination is going to happen. So one of the key questions is in the private sector and in the farming sector, who determines who is essential workers? So you can imagine the retailers and all of those. And then the question would be, would farm workers or people working in agri-processing be regarded as essential workers? And once we have those conversations, then we have a conversation that farm workers can be registered, but they can also then be vaccinated via a workplace program working with the industry in that regard. But any farm worker over the age of 60, our teams will be outreaching, getting them all together, they register on the system, and now vaccinating them according to the age bands in terms of that. Then registration for phase 2, what the challenges was, I think I shared that in the presentation. The biggest challenge for registering for phase 2 is people having access to the means to be able to register. People in poorer communities are registering less. People in more affluent communities have more means to register. That for me is the challenge. And therefore, the targeted strategy is to assist people in poorer communities to be able to register. Then a strategy to deal with chronic diseases and other essential services. That, remember, Windvogel is our bread and butter. We didn't drop vaccinations for children under 1, and we will not drop vaccinations for children under 1. We had fewer people for TB cases detected and fewer people for HIV, and also our chronic diseases, there were fewer people looked after. We have to find a way, and that's why we say flatten the curve. If you flatten the curve, it's not only about vaccinating more people. You flatten the curve, it allows us to maintain those essential services, that we don't neglect the chronics, we don't neglect the diabetics, we don't neglect TB and HIV clients, and we don't neglect children and women that must get the essential services. So it's a balancing act. We must do all of those, but a flatter third wave help us not to neglect those services any further. Then the issue of the West Coast and the Northern Cape. The West Coast and Northern Cape is travel from Northern Cape to the Western Cape. So that's people that live in the Northern Cape that travel on the N7 and come into the Northern Cape, either through visiting families in terms of that. It's not a seasonal worker issue. It is a travel into the Western Cape. The seasonal workers is a different issue. The seasonal workers that we have in this province is mainly an exchange between the farming communities in this province and the Eastern Cape. There is no third wave in the Eastern Cape. There's no third wave in the Western Cape. So the seasonal worker issue has not been a big driver in this specific issue. There are different provinces that has COVID this time around. It's Northern Cape, it's Northwest, it's Free State, it's Gauteng. There's not big migration of seasonal work between those provinces and us. The chronic medication system is a system that we've intentionally designed and will continue. We are not expecting people to come to collect chronic medications. We are taking the medications to them. So our system is designed that people do not come for chronic medication delivery. There's a different question though, when people come to health services for other needs and they're over the age of 60, it is important to check, have they been registered, and as part of their health visit, can they be vaccinated? And that is what the teams are working into their system. Then what happens to the healthcare workers that's not been vaccinated? I made the point that the healthcare worker registration has been closed because people have fraudulently misrepresented themselves as healthcare workers. That's been closed. In that list of people that's not vaccinated in that group, many of them are legitimate healthcare workers. So we're finding a system of slotting the healthcare workers so that they can still come in and be vaccinated. But then there's also healthcare workers that's not yet registered. And we now need to work out the system that they come forward and we know that they're healthcare workers. We will do manual vaccinations on them and then upload them on the system. But we have a system to protect our healthcare workers. And then the issue about registrations. The registrations is the system takes the person that first registered and match them to the nearest site. So if you're on the 16th of April, you registered after 4 o'clock and you're over the age of 60, it's likely that you will get your SMS first in terms of your registration. Now, that is an automated system, but what happens is when you get to geographic areas closer, it could be that somebody registered later, but they are in a geographic area where fewer people registered before them. So there will be a slightly out of step SMS distribution, but the rules has been set up in such a way that it is the person that registered first and the site's coming online. There's been a big issue of people walking in themselves. Our staff has not shown walk-ins away, but are discouraging walk-ins. Because as Member Heron asked, if we're going to scale up to the numbers we're talking about, in 2 weeks' time, we cannot have walk-ins at facilities because there are going to be so many people that got appointments. And we don't want that congestion. So therefore, we're discouraging walk-ins at this point in time. Then Member Heron's questions. Member Heron, the issues I just explained, we can place orders with the National Department based on how many people are registered. When I mentioned that we got 33,000 doses, we got it for the first week, so we have some 20,000 left. Our order actually that we sent in was not for 33,000. We had a bigger order, and we had an order for 90,000, and it's actually delivered. So we currently have 120,000 orders to be able to do the scale up that I described to you. Then increase in pace. I agree with you that you saw the 10,000, 30,000, 60,000, 90,000, and well, 120,000. And I said to you, we will bring on bigger sites. So when we bring these bigger sites on, we are definitely going to open the bigger sites as a 7-day-a-week site. So those are the ones with the biggest capacity. And then our plan is definitely to bring them online and to make them 7-day-a-week sites. And that should happen within the next 2 weeks. Then the private sector delay, I think I've explained the private sector delay and how allocated. Now, the private sector, because they work through B-Force SA, they're supposed to get stock directly from national, and we as a public sector get stock from national. What we've worked with our private sector colleagues is to say, if there's any delay in your stock, we're happy to provide you from our stock, provided we get the stock returned. So there's a system, we're working together, and we are working to make sure that no private sector site actually runs out of stock. The reason why Gauteng did that is because Gauteng, in terms of the big corporates and big private like Discovery and those guys, they had big places where they can immediately go and start the system. In the Western Cape, it is smaller. So I said that 2 Discovery sites are opening here. There's one happening in Claremont. It just opened. It's in the German Claremont. One will be at N1 City where the Discovery headquarters is. So it's smaller. And also then you can hear it's the Clicks pharmacies, it's the Descam pharmacies, it's the hospitals, the 4 Mediclinic hospitals. So most of the sites in the Western Cape will be smaller private sector sites, not those big sites, but the presence will become more and more, and the numbers will become more and more. Our approach here has been to get as many sites distributed so that you can distribute your people over many sites, and you don't have to have big gatherings at any big ones. But we will bring the big sites in for overflow and pace in terms of it. So it's putting a basic framework in place, adding smaller sites so that we can reach out into communities that are less empowered and do outreaches to them, maybe vaccinate and register at the same time, but then have bigger sites where we can take big volumes in terms of it. So that's the strategy of layering what we want to do. Member Marais, the budget cuts over the MTF is a serious concern to us. We have a very clear reality that our 3 priorities this year is we have to vaccinate, we have to deal with the 3rd wave, and we have to maintain our normal services. When we go into year 2 and year 3, we have budget challenges, especially in year 3, to be able to maintain. That's why the vaccination must work. We must get herd immunity so that we can get less impact of COVID, so that we can return to the comprehensive services. But the pressure is going to ask us to do things differently and smarter. It's going to be a big challenge, but we also want to work with the private sector to work differently with the budget pressures that's going to be on the healthcare system. My advice to parliamentary oversight visits, I would say that the advice is to anyone, not just parliamentary oversight visits. If there is a visit that is unnecessary, and if there's gatherings that's unnecessary, I would not advise anybody for the next 4 to 5 weeks. It's our contribution towards reducing the risk for spread. That would be my advice. I think your question about comorbidities and your doctor examining you and saying which vaccine you should have, it's important that people with comorbidities have personal physicians and doctors. There's no evidence, Member Marais, that suggests one comorbidity with one clinical condition does better with the one vaccine as opposed to the other. There is no evidence for that. The evidence we have is either vaccine works perfectly well for everyone, so there is no choice because there's no difference and you can't make a clinical difference in terms of the vaccines. And that has been to an expert committee, and that's the advice. Lastly, on ivermectin, I've asked this question, answered this question before. The High Court ruling, or the court ruling, it was not even a High Court, it was just a court ruling, is that the access must be provided to ivermectin under Section 25 conditions, which means it's an individual clinician initiated and applying to the SAPRA for that clinician to have access to ivermectin. And then there was a ruling, a settlement with AgriForum about that they should allow compounding for ivermectin that makes it easier, that you don't have to go through a Section 25. That is what the situation is. Our stance, and that is the stance that we've always taken, when we advise and we do clinical management of people, we look at the evidence, the clinical evidence. Is there enough rigorous trials to suggest that if you take the ivermectin, it's going to reduce and it's going to impact on the cause of COVID? That evidence is not rigorous. There's not a country in the world where they have accepted the use of ivermectin because the evidence that has been has not passed the muster of the expert committees that looks at it. Now, in our province, we have an expert committee. National, there's an expert committee. Our position is there must be more clinical trials. The moment there's evidence to suggest that ivermectin is effective, like we did with dexamethasone last year, we will introduce the treatment. But until the evidence is there, we cannot write clinical guidelines to say that we will use it in the management of COVID. Thank you very much, Chairperson.
Thank you very much, Dr. Kriti. We'll then move to a second round of questions. We can do, I think we do have a 3-minute, we can do a round of 3 minutes per party, as we do have some time available. So as usual then, I'm going to start with the DA. Are there any questions from the DA?
Yes, thank you, Chair.
Thank you, Honourable van der Westhuizen. Over to you.
Yes, thank you. Through you to Dr. Klute. A, what are the major causes of the 2% loss in vaccinations, and what can be done to lower this number even further? B, would it be possible for a recipient of an SMS to indicate that he or she would still like to be vaccinated, but the time or venue allocated is unsuitable and that they would not be able to keep the appointment? What must such people do? And then C, excess deaths seems still to be the most accurate indication of the prevalence of COVID-19 in an area or province, which means that the closer the number of reported positive cases to the number of excess deaths, the better we are in identifying COVID-19 cases. Would this be true, and how does the Western Cape compare in identifying COVID cases with other provinces? And next question, I learned this morning that the average duration of hospitalization was significantly reduced from the first wave to the second wave. Does this mean that there's been significant improvements in the clinical treatment of patients? And then lastly, what are the latest views on people being repeatedly infected by the COVID-19 virus? Thank you, Chair.
Thank you, Honourable van der Westhuizen. Are there any final questions from the DA members?
Yes, Chairperson.
Thank you, Honourable Philander. You have 1.5 minutes.
Thank you, Chairperson. In the interest of cooperation, what are the department measures are they undertaking to support mitigation strategies pertaining and insurgence of COVID-19 infections at schools? And lastly, Chairperson, when will other essential workers be targeted? Thank you, Chair.
Thank you, Honourable Fernando. If I may, I'm just going to use, just to follow up on your question, just to understand then the sequencing of vaccines. Has the system of essential workers then been abandoned in favour of the age bands? Just for clarity on that. That then concludes the DA's time. I'm going to then move over to the ANC. Honourable Lacka, I don't know if you want to start because you were, I think you had a further question, but I'll leave it up to the ANC to determine in which order you'd like to ask your questions.
Chairperson.
Honourable Winfogel, would you like to start then?
Yeah.
Okay.
Thank you, Chair. Chair, I want to know from the HOD, is there a reason for appointing staff on contract as opposed to employing them permanently, especially given our staff staffing shortage in hospitals. And then on slide 11, can the HOD perhaps shed more light on the school cluster in Cape Winelands? What are the details of the school and what happened there, and how much of a risk are schools and school sports to the Western Cape resurgence? And did the department assist the school? And then my last question, Chairperson, can we be given the reason why the budget for vaccines rollout has been decreased from the original amount stated in the Western Cape budget speech to just 150 million? Thank you, Chairperson.
Thank you, Honourable Windvogel. Are there any further questions from the ANC?
Yes, Chair.
Thank you, Honourable Lekker. You have a minute and a half.
Thank you, Chair. Chair, my question is around the full opening of schools. In light of the third wave, will it be possible that perhaps schools can open in full swing instead of having sessions for learners or dividing learners per classroom? Then, in relation to the issue of workers, at what stage are we going to be opening up for all employees in relevant departments to be vaccinated, because most of those are essential workers? Thank you.
Thank you, Honourable Lekker. Right, then let's move on to the Good Party. Honourable Heron, do you have any further questions?
Yes, please, Chairperson. Just to follow up on the question of the private sector delay. I'm trying to understand Dr. Klutte's reply with regards to agreements around rates charged and fee structures and mechanisms. Is each province doing their own thing with regards to those aspects, or I mean, it seems like the Western Cape has had a delay in terms of activating the private sector sites, but not necessarily the other provinces. So I don't understand that answer in the context of a national program. And then my second question is just with regards to the J&J vaccine. What is the current status of that vaccine? Is the Western Cape Health Department aware of any progress with its kind of mass rollout? Thank you.
Thank you, Honourable Heron. I'm then going to move over to the Freedom Front Plus. Honourable Murray, do you have any questions for this round?
Yes, I'd just like the doctor to expand. He said that the B1531, I think, is the most dangerous. Maybe he can just sort of explain what we should understand by most dangerous. And then he said, every variant responds differently. But I don't understand, because he said there's no proof, medical proof, that COVID responds differently to ivermectin, not ivermectin, to Pfizer as to J&J. But if every variant responds differently, surely that can't be right also, that whether you use Pfizer or whether you use Johnson & Johnson, that it will have the same effect. Just those two questions. Then I would like the last one. I had a case where people in Bishop Lavers, they phoned to my house and they were referred to get their vaccination in Langa. He says, I'm a pensioner and I had to take 2 taxis to get there. There is a facility in Bishop Lavers. I would just like, perhaps it's just an error, or is there a reason why a person staying in Bishop Lavers should be referred to be vaccinated in Langa? Thank you.
Thank you, Honourable Murray. I think that then concludes the second round of questions. I will then hand over back to you, Dr. Klutte.
Sorry, I made a mistake. It's Nyanga, not Langa.
Nyanga, okay.
I was going to answer that now, Mare.
I hope you still have an answer.
No, I was answering Nyanga, not Langa. Thank you for that correction. So I'll start from the top. Just to illustrate to the question about the 2% loss for vaccination. I just have to explain to you what a vaccination program is like. It is about drawing up the dose. It is about injecting it into somebody's arm. Now, if you do 95,000 of those, a normal expected, and this is a norm internationally, as a 10% wastage. It's got to do with how you draw it up. Something unforeseen happen. A vial drops on the floor that somebody couldn't have foreseen. And we're trying, the international norm is that you don't waste more than 10% of your vaccines. That's always been the norm. For this program, because it was so precious for everyone, there was a target set of let's not do it more than 5%. What we've achieved is half of that. Now, really, in terms of vaccine programs and the process involved, to have a 0% wastage is impossible. It is about understanding logistics and allowing for small margins of error, not for whole-scale the dumping of vaccines, of all of that. These are small marginal errors because of the process involved in terms of that. Then in terms of an SMS recipient receiving a appointment at this point in time, my advice, I've got a lot of SMSs and a lot of WhatsApps and things for people, because we're in the early stage and the system must stabilize. My advice to people is if they get the vaccine, if they get the SMS and the appointment, is to stick to it. That is because the system will work on the fact if all of us, again, like wastage, if 10% of people decide that they want to ask, then 20% wants to ask, and then they want to phone, it upsets the system. It is such a delicately poised system, and it's in its infancy stage that we want to run it smoothly. My appeal to everyone is you get an SMS with a date and a time, please respect it and go. Do what you need to do to be able to do. If people cannot do it, they can call the call line, they can have a conversation. There's no guarantee because they will just add again back into the queue to be generated by the system for the next appointment. So the appeal is to ask everybody to stick to the appointment as much as possible. Then the excess death, I lost the member a little bit in terms of where he went with cases and deaths, because deaths is deaths. So when we say the excess death system from the MRC is the only validation tool for what people are doing programmatically internally. The MRC stands away. They do excess death projections based on the data, and they track it with Home Affairs data, and they can extrapolate what is the expected excess death that you want at this point in time, and now the expected excess death, whether you're going above it, and they track those deaths. What we have showed in our second slide is because that is such an important validation, we have done everything we can to verify all the deaths. We get the notification of the deaths. We bring it into our system so that we run our deaths as reported deaths as close as possible to the excess deaths and the deaths confirmed by Home Affairs in the MRC system. So it's really about reconciling your death notification in an externally validated way. Now, there are reports, Professor Sabir Mahdi reported on it a couple of months ago, that I can confidently say that the Western Cape reported deaths is the closest approximated to the MRC excess deaths. In the other provinces, there's a bigger lag between what they report and what the excess death is. And the MRC can verify that specific information. Then the hospitalization duration in the second wave being shorter. The short answer would be, is because there were more people and more pressure on beds for people to admit it, the shorter duration, average duration, was more about pressure for more people to be admitted. That was the short answer. It was not about any different clinical management. It was about more pressure on beds for people to be admitted. Then in the repeated infections, out of the 187,000 infections we've recorded in this province, 3,000 has been people that has been infected, reinfected. So you can also say it's 180,000, 3,000 is reinfected in our setting. So we are tracking that now because we can know that we say somebody has got COVID and we've previously reported a COVID infection against that. So we're tracking that. And as I said to you, 3,000 out of 180,000 cases. Sorry, 190,000 cases it's gone to now. Then in terms of essential workers, and the bans, at this point in time, we're dealing with over 60s because the system has been open for over 60s. The planning is to do essential workers over 60 as part of the over 60 band. It's a simpler system, I told you, and that is what we do. There is a plan, and it's probably called phase 2B, where that is then opened for other age bands, but also open for essential workers. Now, the difficulty that you're going to have with essential workers is exactly the difficulty that we had now with healthcare workers and why we had to close the system. The moment you use anything other than age, the system is open for abuse, because now you have to say who's going to determine on the system whether I'm an essential worker or not, and who's going to check whether you actually fill in the category or not. So there has to be much tighter systems about defining when you open up for essential workers below 60, and the proposal is that it must be 40 and above. And then between 40 and 60, it is how are you going to make sure that there's no abuse of the system when you open that up. The second thing is which categories of workers. As I said to you, it will be public sector. There is a NEDLAC proposal at the moment that it's based on risk of infection and let's call it how crucial the people are to the economy of the country. So those two things. So you can imagine when it comes to public sector, you would imagine that on that profile, police is very high, teachers are very high. So there's no question that teachers and police and social workers will be part of that. The question is which other public sector workers. You can imagine in municipalities, there are essential municipal workers. So that group must be defined and whittled down. In the province, we're already planning for that vaccination together with our colleagues. And then there's in the private sector, whether you then have retail workers and what are like mining and all of those others, which are essential, petrol attendants. There was a big thing about taxi drivers, because taxi drivers are quite essential and they come into contact with people. So it's about having those categories. But my big thing is the moment you open the age groups, there's going to be, you have to have your system so tight that you don't have a repeat of the abuse of the healthcare worker registration that people took advantage of. Then in terms of cooperation with the education department, we've worked with them from the first wave, the second wave. We have continuously working with the education department. They continually ask us for advice, and we're advising them on their protocols in school. We're advising them on everything they do around COVID. And our advice has really been when they have the surge of cases in schools, there's a very clear process to follow. So I'll explain it when I get to Member Windvogel's question, because that's exactly the process we followed in Cape Winelands. And whenever there's an outbreak in schools, the health guidelines guiding education, it's very strictly formed, and our teams work together to contain infections in that regard. So when I then go to the school cluster in Cape Winelands, that's exactly what happened. It was in Stellenbosch. It was a school cluster. It went to the hostel. The hostel was closed. Children were all sent home for isolation. The place has been contained, and all the cases have been contained. And that's not unique to that school in Cape Winelands or in Stellenbosch. It's happened in the second wave and in the first wave. That's the process that we've done. There's very clear protocols. Everybody gets contacted. Everybody gets identified. It gets contained. And that specific case is under containment. The numbers have dropped, and there's no more new cases linked to that specific cluster. The reason for contract appointments is very simple, Member Windvogel. The money we get given for COVID and for vaccines is not money that carries through for 3 years. It's an additional amount of money, and therefore it is only there for a certain period of time. If we appoint the people and we don't have money for them beyond the money of COVID and vaccines getting out of the system, then we carry an over expenditure on our budget. And that's against the backdrop of the wage negotiations and the current negotiations about the impact on salaries and wages. So we don't have money to appoint people permanently. We have enough money to appoint people permanently for the balance, for the budget we have. And that's what we've done. That's the essential posts that we've been filling. But for additional people to come in for COVID and additional people to come in for vaccination, we only have money to buy people's time in for a period of time, and we don't have the money to sustain those posts. If we had money for all of those healthcare workers, we definitely would have put them into permanent posts. But for that, you need to have money that carries through over the MTEF, and it's linked to Member Mare's question. That's the essential part of Member Mare's question. In terms of the budget being reduced for vaccines, I'm not sure what you're referring to, but between the budget speech of the Minister for Finance and the final allocation in the Health Department, there was a decision between Treasury and the Health Department that not the entire amount of money that's available for vaccines is allocated on the books of the Health Department. A certain amount was put on the books of the Health Department, and if need be, the Health Department, if they need to access, they can go to Treasury to access additional money in that regard. Then full opening of schools, that's an education department issue. But again, our education minister and our education HOD consulted us, and there was a national meeting to talk about the full opening of schools. And there was a decision, I understood, in the education sector not to proceed with that before the third quarter. So in July, and to see what happens to the third wave. And then the same issue about workers and essential workers. I think I've covered that. Police, teachers, all other essential workers, government workers. We have a task team in this province. We even have a site identified, and we're working with GEMS, DPSA, so that teachers, all other public servants in this province can be vaccinated. When those criteria opens, we will have the site to be able to start in that. But we can already start with over 60s. But when we open the essential worker categories, then we're ready to gear in terms of that. Just to Member Aaron, just to explain, I apologize, Member Aaron, if I wasn't very clear. The reason is twofold. The one is we have multiple smaller operations of private sector operations here. The big groups that step forward here in the province has been the clinics, the scheme, and also hospitals, maybe GP practices, but the community pharmacies. Now, they are not big operations like the Discovery. Discovery has got a massive operation that they set up at Gallagher Estate, and that's a big operation. So the way I understand why there was a delay is in the absence of clarity of what exactly those rates are. The bigger the organization, the more willing they are to go on good faith and take a risk. So they're saying, look, it's going to be clarified. We will start. We are in good faith doing this because the rates are going to be clarified. And then once it's clarified, it kicks in. Now, if you're Discovery, you can make that decision. If you are Clicks, actually, you can make a decision because Clicks could do it. They could take the risk. But the local community discount pharmacists were saying, whoa, if I take a risk and something goes wrong, I'm laying out the resources. That is very difficult and it's uncertain. So I hope I understand. I've explained that a little bit better to you. So it's a combination of size and it's a combination of the risk appetite in the absence of clarity of the rates and working in good faith that there will be a solution. Obviously, everybody's working to a solution for the rates to be gazetted. Then the Johnson & Johnson status. That vaccine is in the Aspen factory in the Eastern Cape, and it is ready to be used. It has been ready for the last 4 weeks. It is not being released because it's part of an international Johnson & Johnson FDA, USA FDA regulation, that all plants where Johnson & Johnson vaccines are, that they have put an international hold because they had to sort out the quality assurance of Johnson & Johnson factories in other places of the world, not the Aspen factory here. They've got perfect processes. So it's an international hold, and there's a weekly conversation with the Aspen pharmaceutical plant. The moment that hold is lifted, the vaccines will be made available to us. We are working towards the end of May, beginning of June, for that vaccines to join the allocation to the provinces. And then just for Member Mare, I am very sure, Member Mare, I did not say that one variant is more dangerous than another. I did not use those words. What I did say is B1531, which is the variant that was first detected in our country, has become the predominant variant in our setting. It's predominant. It's not about whether it's more dangerous or not. It's predominant. That means it spreads more, and it is the one that if we do the samples, it's the predominant one in our setting. The B117 that was first detected in the UK, a few of those cases, people have traveled here, and we've picked up sporadic cases of that. But it has B117 has never replicated to extent that it's become more dominant than 531 in our setting. The opposite is actually the same. B117 as and 531 went there, it didn't become predominant in that setting. But the interesting one is the new one from India. And that's the one everybody's watching because of its behavior in the UK. It suggests that the B617 that is first detected in India could potentially be challenging in terms of how predominant it becomes in spreading. Now in the UK, it is becoming more prominent, but it's only 10%. 90% is still B117, and all the other variants are also there. So it's your local conditions that determines which is the predominant variant in your setting. It's got nothing to do with whether it's more dangerous and all of those. But that brings me to your question. So what happens is these variants have got mutations on them. And the question has always been, does all vaccines work equally well against the variants if they have a mutation? So again, it's got nothing to do with the comorbidities of the person or the individual, your condition, is which variant you have. In our setting is 531. Therefore, we know that that's the variant that most people are going to get. It's not going to be other variants. Therefore, an individual assessment doesn't determine whether you should have Johnson & Johnson or Pfizer. Our setting and the evidence here is there's nothing to suggest. The people that did the Pfizer trial here, that did the Johnson & Johnson trial, showed that Johnson & Johnson is effective against the variant 531 here. The reason why Covishield was not used, AstraZeneca, because it was not effective. That's why we didn't use, and we had a big delay in our system because of that finding. Pfizer, there's no evidence to suggest that Pfizer is not effective against 531. Pfizer has been used everywhere else, and Pfizer has not been shown to be less effective against any of the variants. I come back to my original point. There is no individual reason why any individual person should get one vaccine over the other. Thank you very much. Sorry, the last one is your corrected question about Bishop Lavis and Nyanga. The Bishop Lavis site started on Monday. The people in Bishop Lavis at the site were setting up the systems. The Nyanga site started last week. And because we're scheduling the appointments, the Nyanga site scheduled appointments went open, and people from Wynberg and people from as far afield as Goodwood and from Bishop Lavis got appointments at Nyanga. The site in Bishop Lavis is open now. The scheduling is now coming through. So it's very unlikely that somebody from Bishop Lavis in future will go to Nyanga. But that's all to do with the timing of when the site comes online, when the appointment slots are made, and when people are allocated to the appointment slots. Thank you very much, Chairperson.
Thank you very much, Dr. Kruti, for those explanations.
Can I just add, Chair?
Yes, thank you, Minister. Please do.
Okay, thanks. In regard to the allocation of the vaccines, from the beginning, because they keep on changing in regard to the availability as we get them on weekly basis. Because remember, Haron was asking about the 33,000 allocation. When there was the 33,000 for us, just making an example so that one can understand the big picture. For Gauteng, the week one for them was 10,000. For Eastern Cape, 16,000. Northwest, 10,000. It was the KZN who theirs was about 77,000. That was the initial allocation. People, it's on the basis of how many healthcare workers they will need to finalize, plus also in regard to their readiness. So as Dr. Kruti has indicated, this amount keeps on being adjusted. And then the question was that, does it depend in terms of the ordering and all of those? It becomes of no use if the national department just gives provinces many vaccines where they ended up not being able to use. And also just to take into consideration, for example, in the Northern Cape, where probably for them, Johnson & Johnson might be far better, or even in other dominantly rural areas, than compared to the Pfizer, where the issue of the storage in terms of the cold chain
and also even when the vaccine has already been mixed and all of those. So probably they will prefer to have more of the J&J, and or even if there's no preference, just make an example for Mpumalanga. If it so happen that they don't have that the storage with them, the big storage sites, just like for us where we, for example, Stellenbosch. So therefore that it does count, because we don't want any situation where you ended up ordering more vaccines and then you ended up not being able to utilize when the others might be able to want to use it. So that now that we are opening up even other sites, specifically like in the community halls and other areas, depending on the readiness of that substructure or on that sub-district, where they could be able to walk-ins, register, and also vaccinate. But at the same time, in others, specifically in health facilities, because we do also have other non-COVID cases that we deal with where the appointment might be crucial. So that's one part of the allocation on the vaccines. In regard to the budget, probably a member Van Vogel was also talking about the whole of the other budget related to the COVID response. For example, the 832 million, where I said then 250 million out of that is for the PPE, because we have to be ready for the third wave, and also 250 in regard to surveillance and also part of the testing and all of those. And also the other one, 332, is for the healthcare in regard to relieving some of the burden on the existing hospitals, especially the central hospitals and the others, so that we can still continue with the Bracken Gate, because we are still leasing the Bracken Gate, also the Songstraal and Mitchell's Plain as a field hospital that needs to be accommodative around that. At the time we said for the vaccine, the 150 million is not all about the purchasing the vaccine, but also all other aspects related to even to the vaccination program on its own, which is we are busy with even right now in regarding to that space. Lastly, on the private sector, on phase 1A, members will recall that for us in the metro, for the healthcare workers, it was only the Melomed that undertook the vaccination of the healthcare workers in the metro. And then outside the metro, we accommodated in our hospitals all others. Fortunately, they coordinated themselves in terms of whether it's a Netcare or Mediclinic, whoever, or the GP or the NGO or anyone who's not in the space of the public, which is it runs smoothly. In other provinces, you might have seen, for example, in the Gauteng, the Mill Park, also in Durban, St. Augustine, and all of those, who also came some later, whilst they were using mostly, like in Gauteng, most of the public hospitals. Now, in the phase 2A, you'll find that now some of these, they applied, noting it's the National Department of Health that accredits a site in regard to the readiness and whether they are ready or not. I mean, readiness and also in terms of the vaccination. Also noting, also it has to go back to the national in regard to the service fee. For example, in the clinics where they can charge, whether 70 rand and all of those. Similar with the child immunizations, which is we were giving to them, and then they will charge the service fee, because understandable is that they might have other things that they need to take care of because they are private. However, it doesn't mean if they run short of the vaccines, we cannot be able to provide them, because they get their vaccines as part of the bigger share, because there's always this percentage, whether that week might be 2/3, 1/3, 2/3 public, 1/3 private, it depends. And then if it might be the next week, it might be 50-50, it depends. But it doesn't mean in that province if the other one has completed their own doses, just like what we saw in the Eastern Cape when their first package was about 16,000 doses, which is they finished them within, because in those spaces, they just made it as that just come. And then that's why now and people ended up still having longer queues and then ended up being frustrated because they drove all the way, they hired whatever in order to come to the queues, like in the SASA, and now there were no vaccines. So that's why it is crucial in regard to the coordination space where we apply the hybrid, the majority of where wait for an SMS and then we come for appointment. The question lastly is about why come, I think it was Member Leka who also asked that, where others who have been called, others not, and also others, they're still waiting. Again, you might probably see that, as I indicated, in most provinces, for the week one, it's about starting slow, and then we increase as the system now tries to strengthen itself. Plus also, they will be adding more of the vaccines, the doses in week 3, where actually the Pfizer, as according to the initial suggestion, information from the national, the Pfizer will come in week 3, which will have more doses. Therefore, most of the people might get most of the SMSs. Now that will be in week 3 or in the first week of June. And then lastly, noting in the first instances, it was the national who was in charge for the whole of the EVDS in regard to the sending the messages. For example, week 1, people just system just released almost, I think, 12,000 or so of the SMS across the country. And then people ended up staying in Fishhook, and then are being told, go to Helderberg, because the system, their system, it might not be able to accommodate, because if there's no other, at the time, a vaccination site that is nearest to the Fishhook, the one that their map picks it up, it will be in Helderberg. At least for now, that the provinces do have an access to the system so that they could be able to, your address, when you said that Smarty Town in Drakenstein, you don't end up going to the Stellenbosch or probably going to furthest, maybe Mbekweni and whatever, because the system could be able to pick up around that part of it. I think that's all, Chair. But lastly, Chair, the essential workers, I think Dr. Kluti did explain that, but it is crucial to understand that it's the same policy wherever you are in South Africa in regard to the equitable access. So whether, because when we open up for the 59-year-olds to 40-year-olds, these are the people who are economic active, population who are at works, wherever they are. So if it's happened that, let's say, Shop right now wants to manage their own using occupational health spaces, because they're still part of the an industry in terms of their responsibility of occupational health, they can open. But it doesn't mean that the 22-year-olds from ShopRite or the 40 or the whatever should be, even if it's not part of their 10. They'll still maintain that it's going to be the 40 until the 59 when it opens up for that age category. So they cannot just vaccinate anyone. If anyone does that, it's not only about breaching the issues on human rights, but it's also being unfair and inhumane when you jump the queue, yet you know that there are other vulnerable people who needs to be vaccinated. I do qualify as a healthcare worker, but still now I've been vaccinated until all the healthcare workers are vaccinated. Of course, there are those who are pregnant who have been delayed in terms of the vaccination, but they form part of the other sub-study. There are those who refuse completely. Like today, when I was in Khayelitsha, there are healthcare workers, specifically contract workers, who said, no, I don't want to be vaccinated. So you cannot force people around that, but we will be watching and see how it goes, because the mere fact that we haven't had received any deaths as far as the time that I was aware of for the past 2 months from the health workers, it meant that the J&J was working. But you don't want a situation of a group or a cluster in a certain facility. They say we don't want to vaccinate, and then we ended up having challenges that we had, like in the second wave, where we have the high level of health workers who are infected, because at this stage we are still, I think, under 30 in terms of the active cases. Thank you, Chair.
Thank you, Minister. It's very encouraging to know that there have been no deaths from COVID amongst healthcare workers that have been vaccinated. That is very good and shows the power of the vaccine. Could I get an indication from members if there are any final questions that anybody would like to ask? If you could just raise your hand, and then that will determine whether we do a final round or move on to our committee admin. does
I
not.
would like, can I ask a
No,
question?
if you could just raise your hand, I just want to get an indication of how many members would like to ask final questions. All right, Honourable Murray, it seems that you're the only one, so I will allow you to pose your final question then.
Yes, thank you. Thank you, Chair, and thank you, Dr. Klute and Minister. I just feel that I want to ask the Minister and Dr. Klute whether they feel it would be necessary that we make presentations about the budget implications that is now the forefront of our concern, and how it will affect his ability to manage the COVID, or isn't it necessary? Do they have things under control?
Thank you, Honourable Murray. That then concludes the questions from the members. I'm not sure whether you, Minister, or Dr. Klute would like to respond to Honourable Murray.
Probably let me start and then ask the accounting officer who's in charge of the money to also to add. I think what is crucial, what he also presented, is about how other non-COVID cases services do impact on the system, like the trauma and all of those. In as much as that we can budget whatever for those, because these are the things that you'll never know that this weekend there might be so many deaths or stabbing or gunshots, in whether in Khayelitsha or Beacon Valley, in Mitchell's Plain, and all of those. But we do know as the communities that where there is a high level of the substance abuse and alcohol, especially over the weekends, the 2 a.m. kind of times where we find that the EMS get those calls. We do know that these have an impact in regard to the to trauma and all of those. Secondly, we do know that most people, the older persons, they are diabetic. And we do know how the diabetes impact on the COVID or vice versa. So that people are still not vaccinated, yes, must take responsibility as health systems, whether provincially or government-wise, in regard to the slow pace. I'm also getting frustrated. I want to have that excitement that we say we child all our vaccines, but at the same time, you don't want to end up collapsing the system. But the point is, we must also take responsibility that to ensure where we are as the public reps, as the constituency heads, and as a pastor dominiers in our churches, to ensure that everyone gets vaccinated, at least by the end of June. My worry is about when we have these 720,000 of the 60-plus-year-old older persons not vaccinated, or not even 80% by end of June. And then there comes the young ones. And then it will be quite chaotic, because noting if the older persons are not, at least the 80% of them are not vaccinated, and we know that they've got comorbidities, it will have a huge negative impact, especially when now we may end up having the third wave. That's why we encourage people to ensure that part of it. And lastly, I like the question when it was asked about the chronic medication and all of those. As I indicated, in Khayelitsha, the presentation that I received was that anyone who's over 60 who comes for whatever reason, not necessary for the COVID, who comes in their own health facilities for whatever, those people need to be registered immediately. And if that site is already providing the vaccines, because not all sites have been activated, provide the vaccines, no older person must leave that facility, whether she or he will have come for the knee, whatever injury, without being vaccinated. So that's why we appeal as the faces of the communities, as leaders and all of those, please make sure that the issue of the trauma and also the issue of the older persons, at least for our side with the healthcare workers now that are vaccinated, it gives us a reassurance in regard that at least people won't need to wear 10 days. People have to be off in terms of the quarantine and isolation. There will be lesser of those, because as we know that even if you are vaccinated, you can still get infected, but at least it won't have dire consequences. And also you can infect the others because you are touching everything. It's just because you're vaccinated doesn't mean that you don't touch and whatever, all of those. So, but at least the system is partly covered that we've got healthcare workers who will be vaccinated. But the system is still delicate if we have got so many of the older persons who are still not vaccinated, because they'll come to us, come winter, it's winter season, come the third wave. Thank you very much, Member Murray. Thank you, Chair.
Thank you very much, Minister. Dr. Cloete, anything further you'd like to add?
Yes, just to answer Minister Murray. So, Minister Murray, Member Murray, we have a weekly engagement. As Minister Mbombo rightfully say, I'm the accounting officer. So I meet weekly with the head of Provincial Treasury and our teams. And we've been doing that for the last 2 or 3 months. It's been extremely good for us to meet on a weekly basis. And part of what we are discussing in those engagements with our Provincial Treasury colleagues is what is our financial situation, how are we spending, what are we doing, and we are jointly building a case for sustainable financing for the healthcare system for the next 10 to 20 years. So our Provincial Treasury, head of Provincial Treasury is engaging National Treasury. I'm engaging National Health. And very soon there will be what is called a 10 by 10 meeting, where all the heads of the 9 departments, Health and Treasury, meets with National Health and National Treasury. And it's really making the case for the sustainability of the healthcare system. So to answer your question directly, we are working very closely with Provincial Treasury. Together, we and Provincial Treasury together will make a case to National Treasury and National Health, and we're looking at sustainability of the funding flows over multi-year cycles. We are saying that as the Western Cape, we want to put that on the table, because actually, when you look at the budget allocations and the budget cuts, other provinces are worse affected than us. So it's a national issue. It's not a Western Cape issue only. And we really want to work through with all the parties in that regard. When it does come to the parliamentary members, it is important to understand that the budget pressures, it requires budget prioritization. And obviously, that's where the difficult questions come in, whether people give money to education or health or to other purposes. And that's a national fiscus, provincial fiscus, and that is the process that we're working towards. I think the Minister makes an important case. We are saying that we can be as efficient as we can be. We can do the right things. We must make sure that we are smart, we are agile, and we are doing the right things. So for the money we do get, we get the maximum impact that we want. So it's about that. And it's also about influencing society for the things that make people ill, so that fewer people are ill, more people are well, so that we can actually have a coping and a well-being society rather than constantly becoming ill. So those are all the factors we're putting into the equation. So my question at this point in time as accounting officers, we're doing whatever we need to do through all the avenues and loops to be able to say that we get sustainable financing out of the system, recognizing that there is a huge financial crunch on the entire country. Thank you very much, Chairperson.
Thank you, Doctor. Thank you.
Thank you very much, Dr. Cloete. I'd like to then extend very big thanks to both Minister Mbombo and to you, Dr. Cloete, and your team for presenting to this ad hoc committee this afternoon and for sharing the information that we've asked for. We've received a lot of very important information this afternoon, and we will certainly do our best in our constituencies to try and flatten the curve in the Western Cape. On that note, thank you very much again for your time this afternoon, and we look forward to speaking to you again in the near future.
Thank you very much, Chairperson. Thank you, members.
Thank you. Thank you. Bye.
Thank you. The committee will now proceed to do some internal administration. So officials are welcome to leave the meeting at this point if they'd so like. Members, I'm just going to get to my document here. I'd like to ask if there are any resolutions and actions based on today's meeting. There is, as always, an opportunity to submit questions or requests for information, resolutions in writing which should please reach us by 12 o'clock on Monday. That's Monday, the 31st of May. Could I get an indication if there are any members that would like to propose any resolutions or actions or requests for information at this point?
Chair, I'd like to propose, if you allow me, that we pass a resolution expressing our gratitude and our thanks to the Minister and her department for the most efficient way in which they are handling the COVID crisis in the Western Cape.
Okay. I'm sure there are no objections to that. I would certainly fully support that. Are there any objections from committee members?
No objection, Chair.
Thank you.
Support.
Thank you. Thank you, Honourable Murray. We will then write a note to the department to say on resolution of the committee, we would thank both the department and the minister for the way that they are managing the COVID pandemic in the province. Thank you for that. That's a very kind gesture. If there are no further actions or resolutions, again, there's that written opportunity that can be used by Monday. We don't have any minutes to adopt today, so that brings us to the end of today's meeting. I'd like to thank all of you for your contributions and your questions, and look forward to the next opportunity where we meet again. Thank you very much. Also to our procedural officers that have assisted in setting up the meeting for today. The meeting is then adjourned.
Thank you, Chair.